I've heard you speak. I heard you speak. Yeah. So enjoy one. Yes. Thank you for remembering. Thanks for sharing. Right. Right. It was just, yeah. Days gone by.
All right, there we go.
Mac.
You have a better mind than I do.
Anyone else? What's your favorite? Did you get this? Yeah, that's for his.
The last 4 years.
You come all the way from Martinsburg?
Yeah.
Oh,
Do you have one? Oh, you do have one, right?
I got one. I sold it a little bit, but I still got one. My wife will have that.
Dan, do you need one?
What's that?
Get one just to have the ball on. I
Okay,
mean, probably
thank you.
same what you got right there, but.
Oh, no, nope.
I educated myself. It's better.
Mm-mm.
Limited what I could do, but it's so glad.
You go on, invite.
We have to get to an age.
Not sure what.
Pause recording, stop recording, break out. I think we're live on Zoom. I think I've got that meeting opened up. Welcome, everybody. Hey, I'll begin the introduction in just a minute. We send this seminar out via Zoom for people that can't attend in person. So I'm watching the Zoom chat room here to bring attendees into the meeting. But this is a great time to turn your phones on vibrate, turn off your ringers, or turn your volume all the way down, so that we don't have any unique ringtones interrupt Dr. Petri's seminar. So I was in training at Naval Air Station Pensacola with a Navy guy, and his last name was Petri. Of course, his call sign was Dish.
Nice.
Oh,
That sounds vicious.
yes,
That sounds pretty scary.
right.
Yeah, does it?
Does it? Well, I would kick this off because it looks like there might be a few tricks on the end. But we want to start on time. It's 10 o'clock. Welcome to You're Not Alone's monthly seminar. You're Not Alone is a nonprofit ministry. We started a couple of years ago with some people that shared similar experiences, and we wanted to provide biblical hope, Christ-centered hope, for individuals, family members, caregivers that were caring for loved ones with the challenges of mental health disorders, addictions, and the like. So we do a Saturday seminar every the first Saturday of each month, and we try to present topics that would be helpful along those lines. We do support groups twice a month, on typically the first and third Thursday evening of each month, where we work through workbooks, we look at some videos, and mostly we close the doors and we enter into a private, confidential environment where we can share our experiences, talk about where we've been, what's worked for us, the trials that we faced, and lend each other support and pray for each other, where that's appropriate. We do that from 5:30 p.m. to 7 p.m. on the first and third Thursday, and Claudio's Pizzeria here in town gives us a 20% discount. So we have the ability for people to have dinner during the first part of our meeting and send in their orders to our group email address ynamforyou@gmail.com. We can put all those things up here at the end of the seminar. And if you want to talk more about upcoming seminars, past seminars, etc., we can talk more about that toward the end of the seminar. This is very important, even though we've got this whole setup. We're live on Zoom. We've got audio recording going, and we record that and save it later and put it on our YouTube channel. YouTube is You're Not Alone Ministry. There's only 2 out there, and ours has our logo on that. You'll see it around the room and on our website later. Now I'll get to the script because Alan, our executive director, is so good about putting together a script so that we make sure that we cover all the topics that we want to before we introduce our speaker. One of the main things that we say before every one of these is the volunteers for You're Not Alone Ministry are not doctors, we're not therapists, psychiatrists, or anything like that. So we're not offering medical advice. We're not offering care of any sort. We're just sharing information and we're sharing our experiences in what we hope will be a helpful way. Let's see. Let's make sure I haven't missed anything. We're just grateful that you're here. Thanks for making the time to come out. And we'd like to open up in prayer. If you care to join us, please bow your heads. Lord Jesus, thank you for bringing us together and once again help us understand the difficulties we're likely to encounter in wrestling with mental illness in the lives of our loved ones and possibly even ourselves. We know you have a unique plan for each one of our lives. Please help us to better understand and better equip ourselves to deal with both pleasant experiences as well as life's difficulties. Please give us the tools, grace, and encouragement to fight this earthly battle and win. Guide us today into an understanding of your perfect plan for our families. And we ask that you be with Dr. Petri as he shares with us, give him clarity, give him perfect speech and thought, and help him deliver everything that we need to hear to care for and provide for the ones that we love. In Jesus' name we pray. Amen. So, I'd like to introduce Dr. Justin Petri. Justin's a board-certified psychiatrist specializing in general adult psychiatry at Valley Health Outpatient Behavioral Health in Winchester. He received both his medical education and his residency from West Virginia University. Justin's an award-winning educator and psychiatrist honored with multiple top doctor recognitions and teaching awards from Eastern Virginia Medical School. Justin's specialties include thought, mood, anxiety, personality, and substance use disorders. So please welcome Dr. Petri.
Can you hear me?
Yeah.
Oh, is it like that?
I'll speak it. Yeah, go ahead.
Test. That's when we thought we had it. Just when we thought it was safe to get back in the water. Test.
Turn them off.
Test.
Something seems live. I don't know what it is. Come on now.
Test. Test.
No, still, we like.
I'm so sorry. Okay. This one I don't think of it. I don't know what it called.
Much better.
Is that better?
Yeah.
All right. I'll just stop being a prima donna. I'm gonna lose my regular number time. All right, guys. Hey, I'm Justin Petri. I'm one of the psychiatrists up at Valley. And it's my pleasure to be here today to talk about bipolar disorder. I used to teach this topic to the medical school students, and so I kind of try to use that and just sort of make it a little bit more approachable to a general population. So for any of you that know a whole lot about bipolar disorder, I apologize if this is a little too simplified, but I tried to kind of start with the idea that this would be for a layman's crowd, layperson crowd. Fair enough? Nice. So bipolar disorder. I ran the inpatient psych unit at Norfolk General for about 11 plus years. And this was really my bread and butter. So anytime that someone was in the midst of a manic episode, or perhaps more commonly a depressive episode, or was suffering from acute psychosis, they would have brought them to me. When I was working at the VA hospital for the last couple of years down in Hampton, they also, because of my experience at Norfolk General, they had decided to sort of funnel all of the bipolar and schizophrenic and schizoaffective disorder patients towards me. So I had about a patient population of about 850 patients. Of those, I would say probably roughly half were bipolar patients. So in order to understand bipolar disorder, I think you really sort of have to start with depression, right? Because the term bipolar disorder really is the newer term that we have for what used to be called manic depression, right? And sort of the classic, I think, mental image that people a lot of times have when they think of manic depression is Vincent van Gogh, or as we call him, Van Gogh, right? And so if you ever read his letters to Theo, his brother, you can sort of watch what was likely a bipolar illness sort of fluctuate over time between these bouts of severe depression and self-loathing, in which he famously cut off his ear, and then these periods of euphoria where he would paint these bright, happy, yellow, sunset, right? So kind of a fascinating historical kind of episode. In any case, depression, probably a lot easier for most of us to grasp, right? We've all sort of been sad. Now, with major depression, it's just taking that a step further, right? The sun doesn't shine on us every day. We all go through adversity. There's going to be good days and bad days. Major depression as an actual diagnosable disorder is a little different, right? It's something that lasts for upwards of 2 weeks. And what you're talking about is extreme sadness for at least 2 weeks. The symptoms that we use there is this. So famously, we torture medical students with this year after year after year. Sticky caps is the symptoms that we use, it's sort of a mnemonic that we use to describe depression. And that stands for sleep disturbance, either increased sleep, decreased interest in things that you typically would enjoy doing, feelings of guilt or worthlessness is our G, decreased energy, impaired concentration, changes in appetite, and that can actually take the form of either an increase or a significant decrease in our appetite. And obviously, that becomes a pretty significant focus of us in treatment, particularly with meds. Some of the meds will decrease your appetite. Some of the medications will increase your appetite, sometimes voraciously so. In that case, obviously, we want to try to tailor that to this particular patient and make it a little bit that is going to match what their needs are. Psychomotor agitation and or retardation, and then of course, suicidal thoughts. Bipolar disorder, you're taking depression and you're adding something to it, right? You're adding a manic or a hypomanic episode. Manic episodes last for 7 days or more, and these are the more extreme version. This is the kind of thing that would have really been brought to me in the hospital. These are the patients that their judgment is so impaired that it's unsafe for them simply to be outside of the hospital, right? And so what one of my professors had once told me was, if you're working in the emergency room and you write in somebody's chart that they're manic, you best be admitting them to the hospital, right? Otherwise, you are really, you are really failing them, and there's likely a pretty significant safety issue that could transpire. Hypomania, on the other hand, much more common, and this is where the diagnostic part of this becomes much more challenging, is the symptoms are more subtle, right? Someone that's manic, you wouldn't have to be Sigmund Freud to pick this out, right? This would be someone that if they were in a public place, they would be causing a ruckus, right? There would be a disturbance. It would go unnoticed by no one. Whereas hypomania, it can be a lot more subtle, and it would probably a lot of times take either a clinician that knows this person very well, or a family member or a friend that knows them very well, information that I take very seriously when I'm evaluating these folks. Is this a significant change for this person, right? And in the case of hypomania, it's a lot more subtle. And so sometimes, if someone doesn't know you, they'll just be like, what a jerk. Like, this person is so out of line. Like, what is wrong with them, right? And they're thinking that this is a much more voluntary process. This person is sort of choosing to be, over the top, grandiose, more aggressive verbally than what, decorum would dictate, right? And the symptoms of mania, we love our mnemonics. This one I find is a little bit less popular, maybe a little bit less user-friendly, but been used for generations of medical students. It's called Dig Fast. And so the symptoms of mania are distractibility. Their thought process is jumping around all over the place. It's like hopscotch. Then we've got insomnia, which I want to really underline this and bold it. It's decreased need for sleep. A very, very different thing than what a vast majority of my patients come in and they say, I don't sleep. And those folks often get misdiagnosed with bipolar disorder, right? Which is a big problem because then they're getting put on medications that are not healthy for you, right? Now, if you're bipolar and you need them, then so be it, right? That is what it is. But if it's someone that really, that's not their problem, then you are now exposing them to what we would refer to as physicians, iatrogenic damage, right? Your doctor's making you sicker. So obviously not a good thing. Grandiosity, flight of ideas, which is, you're again sort of getting back to those ideas bouncing around all over the place. Agitation, pressured speech. These folks are talking a mile a minute. And I've got another thing. I couldn't tell you how many times I've been in the emergency room and people told me they have very, very, very interesting ideas. And so you've got to let me go. I got to go do this thing. I've got this very important thing that I've got to do. Blah, 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 blah. Right. And you, as the clinician, you cannot get a word in edgewise. It's like you have been steamrolled by their words. And it can make it a very, very challenging, clinical encounter that we have. And then thoughtlessness is poor judgment. For instance, I've had manic patients that got very severely injured or in a few very sad instances killed because of doing things that were really euphoric and reckless. For instance, I had a patient that got manic one time. He became hyper-religious. Being religious, that's fine, that's good. But this was a step beyond that, right? This was someone who really, the hyper-religiosity was impairing their judgment. He felt that God had given him a mission. That mission was to go up to Pittsburgh, which he viewed as a den of sin and vice, and go up there and spread the word. Great. However, the means that he chose to do it was to get on a John Deere tractor and drive that tractor on I-79. He got clipped by a semi and somehow miraculously managed to get just a few broken bones and a laceration on his scalp. But, the idea of being hit by a Mack truck at 80 miles an hour obviously is a pretty dangerous thing, right? And then in one case, I had a patient that was not my patient. He was a colleague's patient. He got manic and he drove his motorcycle down the road at 115 miles an hour and ended up getting killed. So it's the consequences of this go beyond just, a mild euphoria or something like that. This is things that in more extreme cases can really be very, very dangerous for everyone involved. Sir.
Yeah, I have someone very dear to me right now, namely my daughter, who was diagnosed recently with cyclothymia. And my question to you is, because she's experiencing it, where does irritability come into this? Because she describes herself as, she's got this. She's every hour, Dad, I'm up, I'm down, Dad. And then when I'm up, sometimes I'm so irritable, I snap at people. Right. Is that?
And that's very common. Okay. And hopefully I'm going to answer that question in just a few slides.
Okay. Yes. Do you want us to wait to the end to ask questions?
Maybe it might be best. Unless you're just dying to know something, then of course.
I'm just afraid I'll forget.
Yeah, no, I've really tried to sort of cast a wide net here with my slides and to cover a large amount of territory. But if you could hold the questions until the end, that might help it to flow a little. There you go. All right, this is sort of summing it up. Cyclothymia. Cyclothymia is just the less extreme version, right? And so if you notice, the high here is not as high. We're not talking about driving our motorcycle 100 miles down the road. We're talking about, I just feel kind of amped up and a little nasty, almost like when yours truly drinks too much coffee. Right? You get that little snark in there, and people, what happens is that people that are cyclothymic, if they're or they're hypomanic, their brain is moving so fast, and they tend to get a sort of a grandiose feeling that they find all the rest of us to be insufferably stupid. Right? And so, when I'm interviewing these folks in the emergency room, it can really be sort of a dance. It takes a certain amount of finesse to not irritate them, right? And they'll get very mad with you, and they'll, throw their stuff down and try to march right out of the emergency room. And in many cases, law enforcement is not going to allow that, right? And so the irritability is sort of a hallmark of this. Now, I would caution people though. I think this is, if I compare a psychiatrist that has experience versus a psychiatrist that does not have experience, early in my career, I would have heard irritability, not sleeping, must be bipolar, right? And sadly, that is not the case, and I'm really missing the mark. Irritability is much more commonly the result of depression, right? If you are not feeling well, then everyone's getting on your nerves, right? And that's a very different thing than that sort of grandiose, everyone's getting on my nerves because they're stupid, right? The depressed folks, everybody's getting on my nerves because I just want to be left alone. I want to be left alone, I'm tired, right? So an important distinction. And what you see here, and this is where it becomes a little challenging, actually quite challenging, is what's the difference between bipolar 1 and bipolar 2? Well, if you have an easy answer, please let me know, because I've been doing this for 20 years, and it's not very easy. Probably the best stab at it that I could make would be that bipolar 1 is the folks that they had to go to the hospital because of mania, right? They ended up involuntarily committed to the hospital, they had a manic episode, and it's really well documented. And that is the more extreme version, right? That high is higher. And what goes up must come down, my friends. So that is the typical pattern, is people become euphoric, and then unfortunately, and this is where it becomes actually in many ways more dangerous, that's that crash. That crash is an extreme depression, and that's where a lot of those patients commit suicide. So the folks that are hypomanic, they tend to, or with bipolar 2, those are the folks that their mania is hypomania. It maybe didn't require admission to the hospital, but if you ask folks that knew them, they'll say, no, there was something really wrong with Cynthia, right? They were not acting right. There was something off. They were too high. They were really irritable. They were doing these things that were out of character and sort of strange for them, right? But they didn't require admission to the hospital for the high. So mixed episodes. Mixed episodes, to try to say that really simply, is I sometimes call it dysphoric mania. So the classic picture that we have of mania is, woo, right? They're high, they feel euphoric, they feel great, they're the life of the party. And indeed, some of the manic patients I've taken care of over the years were the most interesting people I've taken care of. They were really having a grand time, and they brought you along with them. The unfortunate part is that it's very unstable. And so they go from you being euphoric and fun and the life of the party to me on my back being assaulted by a very large man, right? That has happened to me personally. So, it can flip like a switch, and it can be, that's really one of the hallmarks of mania, is that they're very erratic. Mixed episodes are sort of an oddity in which people are both manic, they don't need sleep, they're really revved up, but they're often a lot more angry and sad. And that seems like, a bit of double speak, but it's actually a real thing. I've seen it with my own eyes, and it's a very challenging thing to treat. Frankly, what we end up doing is we treat this like mania. So the treatment intervention ends up being very similar.
D/O mean.
Oh, DO is disorder.
Disorder?
Yes, so that's just our little abbreviation. Bipolar statistics, this varies at whichever source you look at. The most frequently quoted, though, is more like this. 1% of the population having bipolar type 1, 2% having bipolar type 2. So, and of course, this is an area of great controversy. People get really passionate about this topic. There are a lot of doctors out there that will say that the rest of us are terrible. We are underdiagnosing bipolar disorder. I think that that is partially correct. I think that we do underdiagnose bipolar disorder. I think it's more accurate to say that we misdiagnose. We misdiagnose bipolar disorder because I also see a lot of patients that are labeled as bipolar disorder that, in my humble opinion, do not have it, right? They're actually suffering from a different illness that is a lookalike. And we're going to kind of get to the lookalikes a little bit. Peak onset for bipolar disorder is in the 20 to 30-year-old range. It starts, the worse that the prognosis tends to be. Probably the latest that I've ever personally seen somebody develop bipolar disorder was probably in the neighborhood of their 60s. And this is where things get complicated because a lot of times those are folks that have some other sort of biological process going on, some other sort of physical illness that is beginning to manifest itself in a psychiatric or psychological way. Underdiagnosis, as we said, it's often misdiagnosed. Global trends show an increase in incidence and burden over recent decades, particularly in younger adults. This is an area of great controversy. Is there actually an increased incidence of bipolar disorder, or are we just more aware of it? And the public is more aware of it. And the internet creates a lot of self-diagnosis, for better and for worse. Right? It is a lifelong condition, unfortunately. It's a chronic disorder with recurring manic and hypomanic episodes, interspersed with depressive episodes. It requires long-term management. Lookalikes. Schizophrenia. Schizophrenia, the big difference with schizophrenia, because mania and schizophrenic psychotic episodes can look very, very similar to the doctors. Now, that it's debatable as to how important that is, whether we diagnose it correctly, because interestingly, a lot of the treatments for schizophrenia are identical to the treatments that we would use for bipolar disorder. And so in some ways, as a clinician, even if you get it wrong, you get it right. Okay. The hallmarks of schizophrenia is delusions and hallucinations. Certainly the classic image I think that most people have of schizophrenia is people kind of talking to themselves. That certainly is a big part of the disease, but it's not exclusive. Disorganized speech, disorganized and catatonic behavior. They're odd behaviors, but they tend to be less euphoric and intrusive than what we see with the bipolar mania people. And then anxiety. Anxiety is a little harder to define, I think, than we give it credit for. So, anxiety and depression are probably the most common reasons why my patients come to me and they cannot sleep. I cannot sleep. Please give me something, make me sleep, knock me unconscious, right? And this, I think, is where a lot of the misdiagnosis comes in, is that people mistake the idea that they couldn't sleep because they couldn't shut their mind off to the process that we see with bipolar mania or hypomania. And this is an important distinction in my world because the treatment is in fact different. If you have anxiety, I'm probably going to put you on an antidepressant, right? Because that's actually the first line for anxiety is antidepressants. So we use those. Now, if I gave you an antidepressant and you have bipolar disorder, sadly, it's probably going to make you feel a lot worse. And so we have to be careful and make that distinction. This is where I really sort of pause the interview and say to the person, let's be really careful about this. And let's make a distinction. Are you unable to sleep because you are thinking about things and worrying about things, underlying worry? Or is it that you feel like you don't need sleep, right? You're euphoric. You are the Energizer Bunny, right? And that's an important distinction for us. PTSD. And PTSD we think of as with soldiers, right? And as my image here is, PTSD actually is much more common in civilians than it is in soldiers, right? Because it doesn't matter, you don't have to be exposed to combat to have PTSD. And in fact, the much more common, sadly, form of trauma that people have is childhood trauma, whether that's physical abuse, emotional abuse, sexual abuse. And that can have a very profound lifelong effect on people, which can in many ways resemble the things that we see in bipolar disorder. Folks that were physically abused and emotionally abused and or sexually abused growing up tend to have a heightened sense of threat, right? So much so that they lash out they lash out. You know, they always feel like people are sort of victimizing them in some way. They feel very, you know, and they often will tell me that they're paranoid. And that's also not quite right. And that's an important distinction for me. Paranoia is schizophrenia. What they have is hypervigilance. Hypervigilance is a threat response that has to do with trauma, right? My soldiers that I was taking care of down at or more frequently seamen, that were down at the at Norfolk and in Hampton at the VA, these were people that were lashing out because they had been exposed to combat, right? So a little different thing that would get them hyper aroused. This is one of the most common lookalikes is the cluster B personality disorders, particularly borderline personality disorder. These are folks that, because typically stemming from a history of childhood abuse, they have sort of erratic behaviors. Their mood tends to fluctuate really rapidly. They go from being semi-euphoric and maybe a little, mildly euphoric to more frequently very dysphoric, right? Dysphoria is unhappy. So they are really irritable. They're very unhappy, and their behaviors can be erratic and impulsive. It's just for a different reason. And so again, this is an important thing for me to try to distinguish because the treatment is going to be different. Pills do not work for this, okay? And I would love to tell some of my physician colleagues, pills don't work for this, okay? And sadly, a lot of people with these disorders are not getting the treatment that they really should get, which is psychotherapy. They should get trauma therapy. That's what's going to help them. My pills are a Band-Aid at best, at best.
Wow.
Then we've got, of course, substances. Substances are always in the mix here, right? Substance abuse, alcohol are sort of endemic to this population. I think a lot of it stems from vain attempts to self-medicate, right? I'm feeling depressed, and so, or I'm feeling anxious, I'm feeling revved up. I need to take something to help stop this process. I need to feel different. I would do anything to feel different. And so, unfortunately, these get thrown into the mix, and they tend to just complicate things and make things much messier. So, determining treatment. First question, especially when I see somebody in the emergency room, is does this person need to be hospitalized? Is there something acutely unsafe going on that necessitates being in the hospital, either voluntarily or, unfortunately, in a few cases, involuntarily, right? Getting a court order to force somebody into treatment, which is not something that makes most of us feel too good, but unfortunately, it's just part of what we have to do. It's part of our responsibility. Psychotherapy. I am a huge psychotherapy fan. I love it. I think we should all be getting psychotherapy. We need many more therapists in the world. Therapy tends to work better for depression, anxiety, and some of the other illnesses out there. Certainly can be used in the case of bipolar disorder, but it's not really the foundation of the treatment. Bipolar disorder and schizophrenia have a sort of a stronger biological underpinning. And in most cases, they're going to require some pretty significant medications here. Okay. Medication, I'm going to get to all the medications. I've got a bunch of slides that sort of go through all the meds. This is really my forte, so I'm going to try to dig into that. And then, of course, I would be remiss if I didn't include ECT. ECT is electroconvulsive therapy. That usually shocks people that we're still doing this.
Good one.
All right, I know.
Good one.
Hey, this is the best I can do on a Saturday morning. Thank you. You're a lovely. Hey, you're a lovely audience. You're a lovely audience. So it's ECT is still something that is done. It's done in the United States actually more than it is in Europe. I think we should take pride in that. It's actually the best treatment for depression by far. Best being most effective, not best. I should probably not say best, right? Because it depends on the patient's circumstances as to what's the best fit for them, right? But ECT is certainly an option for these folks. It has been shown to be extremely effective both for depression and for acute mania. Thankfully, we don't have to use it all that often in mania because over the years there have been some advances in the medications that we have available to us for mania, and so it's just not it's not often necessary to use ECT. It's just a big thing to go through, and I'll kind of get to that hopefully. And then social and family interventions, which is kind of what we're doing here, right? Educating the population, explaining to them what's going on. Early intervention, right? It's a lot easier to kind of pick somebody up that's going up or going down as opposed to someone that is up or is down, right? So we want to intervene early. That makes a huge difference in how those patients are going to respond to treatment and the damage that's being done. Because in some cases, people can cause tremendous damage to their lives while they're hypomanic or especially manic, you know? Things that unfortunately a lot of times can't be taken back. You know, I've seen the number of times that I have seen bipolar mania ruin marriages is innumerable. I cannot count that high. And it's a sad thing, right? It's sad to watch these things happen. So the medications, they sort of fall into four major categories. Antidepressants, and I noticed when I was going through this, I actually sort of put one of my slides incorrectly towards the back. So I apologize for that. But antidepressants, just suffice it to say, of course we use antidepressants, right? We try to get that depression taken care of. There's a lot of times comorbid anxiety problems in these folks. Bad things run in packs, right? Unfortunately. So when it rains, it pours. Most of my folks that have bipolar disorder, they've also got an anxiety problem, and they may have a substance abuse problem, often a trauma history, right? And so it's tough because it doesn't exist in a vacuum. If bipolar disorder existed in a vacuum, the smart people would tell us, you're a bad doctor if you give them antidepressants. But sadly, that's all we got. And so a lot of times we're backed into a corner and we have to use them. We just have to use them carefully. So mood stabilizers, really the hallmark and the foundation of our treatment is going to be mood stabilizers and/or, oddly, antipsychotic medications. Specifically, the second generation antipsychotic medications. These are things that came out while I was a medical student. I remember that the psychiatrists just were beside themselves. They loved this. They were so happy. This is going to change medicine. And then the honeymoon phase sort of ended within a year or a year and a half when we realized that these medicines were causing tremendous weight gain. And of course, all the problems that sort of go along with that. But I digress and I'm getting ahead of myself. Mood stabilizers. Again, like I said, this is the foundation of our house. Most common ones, lithium. Almost everybody's heard of lithium. Even the term itself has so much power. It's got a valence to it. I just sort of watch when I even mention lithium, whether the person cringes or not. You know, lithium has been around for ages. It was actually invented over 200 years ago. They didn't know how to use it. They were poisoning people, so then it disappeared from medicine for 150 years, and then they sort of rediscovered it in quotes in the 50s. It's interesting because lithium, if I were your teacher, sadly, if I were your teacher and you were in my class and I was going to give you a test, the right answer on the test is lithium is the gold standard for bipolar disorder. You know, sort of. Nothing's ever shown that it works better for lithium, you know, better for mood problems than lithium. However, its side effect profile is really not very friendly. It's got a lot of baggage that goes along with it. And so frankly, we don't use it, you know, we don't use it a whole lot because it's just not very user friendly. It takes a very special patient who's going to be really responsible for taking the medication on time, taking it exactly the way we prescribed it. And then you have to have a good doctor who's being really vigilant about monitoring your labs, taking into account what's your lithium level, how are your kidneys doing, what's your thyroid up to, right? Because this medication is not healthy for you, right? Sadly, none of the mood stabilizers and none of the antipsychotics, they're not good for your body, okay? And that's why this is so important that we get the diagnosis right. Because again, if you need it, then so be it. But if you don't, let's get you off of it, right? This is not healthy for you. All right. So
AEDs?
AEDs. Yes, I was going to say that.
AED.
AED is anti-epileptic medications.
Oh,
yeah. So lithium, most effective ? Risk of acute toxicity. If you get dehydrated in the summertime, increasingly a problem, right? As it becomes 1,000 degrees out. in the summertime. I moved up here from Norfolk. It was brutally hot the last couple of years. People were getting sick on this stuff, right? Because they go just walking out to your car, walking downtown for a little while, gets you dehydrated enough that your lithium level is starting to get too high. That can make you sick. In extreme cases, it can actually require dialysis. There's risk of both long-term effects on your kidneys and your thyroid gland. Typically, it causes your thyroid gland to become hypoactive. In other words, it's producing not enough thyroid hormone. That's a big problem. And this requires frequent lab monitoring on the part of your doctor. Anticonvulsants, probably the one that's most famous and or notorious is Depakote, requires a lot of labs to monitor damage for liver and your blood cells. Patients often dislike it because frequently there's weight gain, some sedation, and I would say really most frequently, as I have heard over the years, was the cognitive side effects. People would just say that they feel sort of blah. They feel a little spacey. They don't like the way that they're feeling, okay? So thank you, doctor, you've kept me out of the hospital, but I'm not really enjoying my daily life, right? And so, again, that's not the case for everyone. I've had some patients that have done very well on all of these medications. It's just those are frequent complaints that I hear from people, okay? Anticonvulsants, carbamazepine. We hardly ever use this one anymore. The reason for that is this thing. Autoinduction is a weird phenomenon with this medicine because what it does is it revs your liver up like crazy. Your liver becomes a very robust factory that is chopping up medications that have nothing to do with your psychiatric care, right? And everything to do with your cardiac care. And so this can cause a lot of problems. I have always not liked this medication. I always thought it was really, really difficult to use. For a long time in my early training days, we had to use it because the insurance companies would not pay for anything else, right?
Oh my.
And this was on the $4 list. So this was something that we could get for $4 at Walmart. It meant that even my patients that were homeless and indigent could probably get this. And so it was sort of a necessary evil. Suffice it to say, the reason that we don't use this too often anymore is that effect of revving up your liver causes a lot of problems with your other medications. So if you're a person that needs blood thinners or you need something for other medical conditions that require sort of a narrow window of operating, what we would call a therapeutic window, then it can throw you out of that window and cause some pretty big problems for your physical health. Its close relative, thankfully, is much better. Love this medication. This is great. We get a lot of the good without most of the bad. So oxcarbazepine, known as Trileptal, it was in fact an anti-epileptic medication initially. It's largely replaced carbamazepine. Has a similar sort of side effect profile to carbamazepine and Depakote especially. It causes a tiny smidge of autoinduction, that effect on the liver, but not too much. Not enough that it usually really is going to bother us too much or irritate my friends in primary care or cardiology. Again, though, we still need to get a lot of labs here because it can damage your liver. It can cause, especially common problem is low sodium. Low sodium is a big problem, so that can make people feel really off physically. It can make them feel pretty ill, and cognitively, it can really impair their ability to function. So just something that we always have to sort of be watching what we're doing. And then the new kids on the block, that's what we used to call them when I was in training because they were fairly new, often very expensive. And, now with the passage of time, most of them are generic. And so we use the heck out of these things. I would say, generally speaking, these are probably more commonly used than the other mood stabilizers, just because as a general rule, people, I think, feel different and they often feel better, feel in the vaguest sense, right? I like the way my mood has been. I like the way I feel. Unfortunately, and the major problem here has to do with our metabolism. They often will cause, and ironically, the ones that have often shown themselves to be the most effective are also the ones that often tend to be the most damaging to our metabolism. A sort of unfortunate irony, right? Zyprexa was the first one that came out. That's olanzapine. Seroquel, which I think almost everybody's heard of, quetiapine, very frequently used medication. A lot of patients like this one specifically because it sedates the heck out of them and it'll help them to sleep. Please make me sleep, right? Probably the most common thing that people come into my office and say, please make me sleep, right? I'll do anything, get me to sleep. Sure, quetiapine caused me to gain 200, 100 pounds. So be it. I'm at least sleeping, right? And that is the kind of stuff that I hear. Risperidone, a close relative, it was really frequently used before this one came around. This one's got a certain amount of notoriety because if you watch TV, especially late night, the lawyers are all out and about, right? The ambulance chasers. If your doctor gave you risperidone and you developed female-looking breast tissue, then call, Schlichter, Howe, and James, right? I mean, this is sort of a notorious problem with this. Thankfully, it's rather rare, but more commonly, the thing that caused that development of breast tissue is a common problem, which is an elevation of a chemical, a hormone in your body called prolactin. Prolactin is not a healthy thing for you. It causes osteoporosis. It's not supposed to be there unless you're having a baby. And so, it is a pretty big problem that goes along with that one. Paliperidone, thankfully, it's a little bit better in that regard. However, all of these cause weight gain, a lot of weight gain, particularly this guy.
Oh, wow.
Yes, olanzapine is perhaps the biggest offender. Fanapt, iloperidone, we don't use it a whole lot. It never really carved out a niche for itself, so we don't see this one too often. People loved this one, Abilify. Very frequent, actually for a while, I think it was several years in a row, Abilify was the #1 most profitable medication in the world of all medications because it cost $500 a month and somehow people loved it, right? We frequently use it for sort of mild bipolar cases, bipolar 2, depression. It's shown itself to be useful as something that sort of boosts your antidepressant up. A lot of the patients like the way that it makes them feel because it gives them a little bit of stimulation, so they feel like they got a little more energy, a little more pep. Yes, please. And so this is a really common medication. Now, it's not quite as bad when it comes to the weight gain. However, I have certainly seen people gain weight on this before. So when people come into my office, I always warn them that this is a possibility. As we said, the weight gain and the problems that go along with it is really the major problem with these. When you start to gain fat tissue, your metabolism goes haywire. You start to have a lot of problems with glucose insensitivity, insulin problems, right? And so this becomes a really big issue. People notice that their blood sugars start to rise and rise and rise. And then hyperlipidemia, which is our fancy doctor word for high cholesterol, right? High cholesterol and high triglycerides can both be a problem. Specifically with quetiapine, it's notorious for causing people's triglycerides to skyrocket. That can expose you to a whole bunch of other problems, such as pancreatitis, which is no joke. Some of the sickest people I've ever seen in my life were pancreatitis cases. Long-acting injectables. I love these things. I cannot underscore enough. When I go to conferences, back in the good old days when we could actually go somewhere, right? This was really great. These medicines they've changed the landscape. The data is so clear that it's hard to remember to take a pill every day, and especially a pill that you don't necessarily like that much, right? Like I don't feel better. This is not my nerve pill that makes me feel great. This is not something that really is. They're not fun, and so a lot of times, people sort of neglect the medications. They honestly just forget, and once that starts to compound and go on for a few days, it just snowballs. Yep. And before you know it, this previously stable patient is now really struggling. Their mood is too high, their mood is too low. And this has really changed that. The data for this, the number of hospitalizations that people get for these very expensive medications, the government decides, and all the insurance companies, I want to say that again, all the insurance companies actually pay for these. Yeah. And the reason, I don't mean to be cynical, it saves them money. Yeah, right? It's expensive being in the hospital, right? So aside from just the human cost, if you wanted to be cynical and jaded and just talk about the money, this actually saves them a lot of money despite the cost involved. And Megatrinza, I think, is like almost $2,000 a month, or for a 3-month supply. This one here in Vega Sistema is about $1,200 a month. And that's a significant amount of money. However, it's still saving them money because a single day in the hospital is more than $2,000 a day. Right? And the average length of stay for someone that's manic is going to be about 2 weeks, 3 weeks. So you've more than paid for this. But from the more human side of this, the patients are just doing better, right? They're not having these huge, undulations in their mood, and so they're living their life in a much more normal way. I particularly love this one. I had a lot of patients when I was at the Hampton VA on this, in spite of the metabolic problems. I just really tried to be vigilant about it. Trying to be honest about it, right? To my patients, this is something that could happen to you, or this is happening to you. So what's our plan? What are we going to do about this? How much of this can I manage myself? How much of this do I need to pawn off on or coordinate with your primary care physician, right? Invega Half-Yera, rather clever. Whoever came up with that name got a raise, right? It lasts for a half-yera. So it's a 6-month injection. We didn't actually have any patients on it at the VA. The VA would pay for Trinza, no problem, no questions asked. But for whatever reason, they would not pay for Half-Yera. I tried to get a couple folks on it. It never happened. One of the pharmacists that worked with me, who was wonderful, he had a bit more experience with Half-Yera. He just said that he didn't like it a whole lot because it didn't quite work as advertised. He said that it was wearing off a little too fast. And so if you had fought with the insurer to get it in the first place and they would only pay for it every 6 months, he said that was causing some problems towards month 5, where it was wearing off a little bit too early. Abilify Maintainer has been a really nice thing. Abilify Aristata, 2 different companies, 2 different products, although they're similar. They're both aripiprazole, is the generic name for this, but they last for a different amount of time. And there's a different sort of, I won't bore you with all the details, but it's a little different initiation process for both of them, and they last for a different amount of time. Some patients will prefer one versus the other. We had a lot of folks on this because it could last for 6 to 8 weeks. Fewer shots per year means fewer lost opportunities, right? Fewer opportunities to miss the shot. Right?
Yeah.
And again, not surprisingly, perhaps, when the smart people count this up and they study these things, the less times that you have to be stuck with a needle per year, shocking, the more likely people are going to do it, right? It's not pleasant to get stuck with a needle. And the good thing that actually is really nice about these compared to the other antipsychotic medications that came out in the 60s was Haldol and flufenazine, if any of you have ever heard of those. Those are long-acting injectables really specifically for schizophrenia. Those are a big grease ball. It's almost like you've stuck this sort of like big lump into your backside. And it's uncomfortable, right? You've got this thing that takes up space. And so it's pushing on your nerves. And so people just generally don't like it, right? This is nicer because it actually it does not create a space lesion in the person. So it's sort of just, it dissolves out into the tissue. And so most of the patients will say that it's no different than getting their flu shot, right? Which is to say they'll have some soreness or some redness right around the injection site. But for the most part, that is a really transient thing. Doesn't seem to bother them nearly as much. All right, our metabolically friendly SGAs. Having grown up in West Virginia, King Cole, Well, here's the mental analogy I'm going to make. For our metabolically friendly SGAs, or second generation antipsychotics, it's a little bit of a misnomer. This is clean coal. You know what I call clean coal? Less dirty coal. Right? It's not really, I think, safe to advertise these as metabolically friendly. They're less evil. Okay? These are less likely to cause the weight gain. They're less likely to cause the problems with the blood sugars and the cholesterol. However, we see there's always a cost, right? Have you noticed this? There's always a trade-off. It's a rip-off. So here's the trade-off. There's a very significantly increased amount of a thing that we call akathisia. Akathisia is a fancy word for an inner sense of restlessness. The patients that have akathisia, they feel like they cannot sit down, like, and it is really unpleasant. It actually is considered dangerous because it's so unpleasant and it doesn't go away that there's actually been some case reports of people that injured themselves or actually attempted suicide because they just want it to stop. Please make it stop, okay? And it's actually a difficult thing to make stop. Sadly, more often than not, you probably have to sedate the person. you stop the medicine that's doing it in the first place, right? Step one. Step two, though, is you're probably going to have to use some sort of a sedative. And now we're starting to get into things that can be a little more require finesse and be a little more dangerous for people. So not a fun thing and not something that we would take lightly. Here's my misplaced slide from earlier as advertised. Antidepressants. Should we give people antidepressants when they have bipolar disorder? If you read some of the journal articles, some of the large studies that come out of Europe, medical studies that are done in Europe actually tend to be better than the ones that are done over here. I'll tell you why. They have national health systems. Those national health systems, I know, I'm gonna, and I'll stay out of the politics. The national health systems, they do lend themselves, despite all of their flaws, they lend themselves to the gathering of data, right? And so it's a convenient place for scientists to study. What the British showed us was patients that have bipolar disorder that are given antidepressants have worse outcomes, in quotes, right? So now, how do you define worse outcomes? I think in their case, it was increased number of suicide attempts, increased number of suicide completions, hospitalizations, length of hospitalizations. So I'll give them credit. Those are some pretty good landmarks, right? Of course, there's all sort of complicating things that go into these and biases and things. However, the problem with that, I would be willing to concede, and this is what they're saying. If you give people with bipolar disorder antidepressants, you are making them more unstable. So you've helped with the depression, but that's great. But now you've caused an increase in that fluctuation of the mood.
wow.
And so are you increasing the amplitude of those waves of mood that are hitting people? Perhaps. My counter argument would be our patients aren't just bipolar, right? Unfortunately, like I said, bad things run in packs. People with bipolar disorder are much more likely to have problems with anxiety. It's almost endemic. And so it's a lot, if we lived in an imaginary world, if we lived in a perfect world, there wouldn't be bipolar disorder. But, if we were going to try to treat it in a vacuum, sure, I would be willing to concede we're only going to use mood stabilizers. Patients in the long run will have better outcomes. But that's not real life, And so most of the time we find ourselves trying to use the mood stabilizers or the second generation antipsychotics as sort of an insurance policy, the thing that's going to keep the lid on the pot, right? That's going to keep that mood from getting too high. But in the meantime, we've got to treat those lows. We've got to treat the anxiety. We've got to treat the panic attacks. We've got to treat the PTSD that is often going to be present side by side, right? So, and that's where the finesse comes in. As promised, here's my ECT slide. It is in fact still in use today for refractory or urgent cases. Nothing works as quick as ECT. We had a patient one time, I remember, who was just bouncing off the walls for a month. And she was not my patient, but man, I saw her. We all saw her. We all heard her, right? I mean, she was really, really manic. She was very wound up. And my colleague, who was wonderful, this German lady, she was just trying every medicine known to mankind. I mean, it was like the medicines were just bouncing off. They're having no effect. And that's an unusual thing, thankfully. But I remember she got this young lady ECT, and within one session, it stopped.
Wow. Yep.
And by 2, 3, 4 sessions, everything had really stabilized.
Yeah.
And then she was very rapidly able to just switch to once monthly ECT for a while and then presumably drift off and not have to do it at all, hopefully. She was doing remarkably well when I saw her outpatient, did one of her ECTs for someone that was out on leave. And so, I mean, it really does work. It's just a lot to go through. You're being put asleep, which is not pleasant and can be a little dangerous, just a little bit, like getting your tonsils out. I think it's actually the same risk. So we don't generally think of getting our tonsils out as, the worst thing ever. But there is a certain amount of risk, right? If you do that 10,000 times, somebody inevitably, based on the numbers, is going to get hurt, right? So the major side effect, though, for ECT, far and away, memory impairment. And the memory impairment tends to be short-term, okay? So these tales that I've heard or that you read on the internet about, I got ECT and it ruined my life. I never remembered anything after that. I think that those are a little exaggerated. my personal experience, what I've seen with it, it's very problematic. It's certainly very annoying. It's a little scary for people when they can't remember stuff, right?
Yeah.
They sometimes don't remember the few hours around ECT. Sometimes they don't remember the day of ECT. Sometimes they don't remember a couple days around ECT. And in the case of my young lady that, had the terrible mania, got better, she did not remember the entire hospitalization.
Wow.
5 weeks.
Whoa.
She had really fixated on me. She had some very creative names for me and, would just curse me, and she would give me a good cursing every day. And, when I saw her for outpatient ECT, I said, yeah, hey, I'm Dr. Petri. And I just got a blank stare. Didn't remember me. And I was like, you don't remember me? She was like, nope. And I was like, wow, that is fascinating. Man. I mean, like, you were really fixated on me. I mean, like, I was public enemy #1 while you were in the hospital. I mean, you would give me a good cursing every day. And she was just like, I am so sorry. I don't remember a bit of it. And I told her, I didn't tell her this story to make her feel bad, of course. It was just, I literally was shocked. Like, she did not remember me for 5 weeks worth of remembering me. Now she was back to functioning. She was actually a really high functioning young lady. Went back to work, relationship. I think she was set to be married. So, I mean, in her case, ECT was a win. It really worked. Okay. TMS, I'll make this quick. TMS is a thing that they often use for depression. Can I sigh loud enough? It looks so tempting. I've been to these conferences where the smart people from Harvard and Yale and all of these places, they're really trying. It's never really quite panned out. I haven't been too impressed with it. It was sort of marketed as bipolar light, or, ECT light. This is going to be sort of using magnets and electrical impulses to change the flow of current in your brains, get your depression better. I've had really middling results with it. I've had a few patients that it seemed to help them for their depression, but I would say the fails are a lot more notable to me than the success stories. Thankfully, the side effect profile is certainly a lot more benign. It doesn't really do anything bad to people. It's annoying to feel. It actually feels like someone flicking you real hard in the head. That's the electrical impulse. I actually sat in the chair and had it done to me. It's not the kind of thing that I would enjoy for half an hour. But I mean, if it works for that particular individual, then so be it. Sadly, it hasn't really been it has not been as effective as we had, I think, the initial interest in it. Here's bipolar in children. This was my last couple slides. Now, this is sort of getting a little out of my comfort zone. I don't take care of children. I did some child psych when I was a resident at WVU. I think we did a few days every week for a year or so. Bipolar disorder in children is a highly controversial area. Can children have bipolar disorder? If they do, how do you diagnose it? How young can they actually be? This opens up a hornet's nest of sort of ethical issues. Are you talking about giving children lithium? Are you talking about giving children second-generation antipsychotics? Thankfully, that's not my decision to make. I don't treat this population, but suffice it to say, it is an ongoing area of medicine. There's a lot of research in this area, to try to tamp it down, figure out what it is, and determine, if we're going to diagnose this, do we use the same criteria as we would in an adult? That's what we typically did. Certainly, when I was a resident and a trainee, we would say we're going to diagnose this only if that child is exhibiting these mood symptoms that last for, these outbursts and irritability and in some cases destructiveness, that is lasting for a week or for 2 weeks or something like that. And then they have this sad, this depressive episode that sort of comes behind it. But suffice it to say, it's a really tough area, right? How much of this is learned behavior and or trauma, things that we would perhaps attribute to ADHD or to conduct disorder or oppositional defiant disorder, which are all sort of separate illnesses. So just wanted to plant that seed that it is something that they talk about. There certainly are children that are diagnosed with bipolar disorder. Like I said, it's a pretty controversial area as to what defines that particular illness. So I believe that that is my last slide. Oh, no, here we go. Just a couple more, but it sort of is reiterating what I just said. All right, guys.
Well, yeah, so what, are you open to,
Absolutely.
question and answer period?
Questions? Hopefully I got some answers.
Anybody on the Zoom wants to ask a question?
Sure.
Justin, Valley Health's outpatient behavioral health unit. Can you provide some information of what all kinds of services you do there? I know you're building a new building. Just, I guess, give us a little bit of information on what kinds of services are available through the outpatient behavioral health unit.
Sure. It's a tough question to answer, and I'll try to give the most candid answer that I can. For right now, our bipolar program is me. Yeah. Unfortunately, there's only, we have a very small number of medication providers right now. We're the predominant outpatient service that Valley has at the moment is the partial hospitalization program, or actually we call it an intensive outpatient program. When I was back was a trainee, we would have probably called a day hospital, right? So it's sort of like people that are one step away from going to the hospital, or they just need more. They need more than the occasional once monthly medication check, or the once weekly individual therapy, right? These are folks that need a little more support, and so they'll come in, in many cases every day or a couple days a week, depending on the patient's circumstances, for a half day, and go to some group therapy, have some individual therapy on top of that, and that can last for weeks to months. And certainly the hope there is that we can, and there is a medication provider that works with them, Dr. Mary Rhodes. She's my colleague. She's wonderful. I think very highly of her. She was actually Doctor of the Year a couple of years ago. I saw her picture up on the wall. I was like, hey, I know her. So she does a nice job. But it's just one medication provider. Then otherwise, if you're not in the intensive outpatient program, there's one physician, and then I think we have 2 NPs at the moment. Nurse practitioners, they sort of function almost like a physician assistant would, or kind of in the same sense as a resident would work. They have a physician that's sort of assigned to them that provides some supervision and consultation. I work with at least one NP that has been relocated to New York, and she continues to work with us via telemedicine. Which I think just sort of shows the desperation that we have, right? We've been really actively trying to recruit other physicians. We haven't been successful up to this point. I'm not sure why, because I find the Shenandoah Valley to be lovely. And so, we've definitely been trying. We've been trying to attract some more. I mean, we want more of everything. We want it all. Remember the Queen song, "I Want It All, I Want It Now"? So we've been trying to get more therapists. We've been trying to get more medication providers. We're interviewing candidates. We haven't had too much success just yet. As they alluded to, we have a new building that we're building that's, because right now I'm like one street removed from Winchester Medical Center. We're sort of tucked away amongst a bunch of like dentist office, and I think there's an orthopedist office next to us that's great big. And so, we're sort of tucked away, and we have like a little tiny workspace. Next year, I believe in October is what they've been telling us, the new building will open up. It's much larger. They're going to take the child psychiatry service, which is now over kind of by McDonald's on Amherst. Everybody probably knows that one. That's a landmark. And so, the child psychiatrists and therapists are over in a separate building right now. They're going to be moving into the same building. We'll have separate entrances, is my understanding, because I think it's a legal thing, or maybe just, I don't know if it's a legal thing or maybe an ethical thing.
Probably.
They sort of have it so that it's separated. One half of the building is going to be like for the child psychiatrists and those folks. They enter through a separate door than the adult patients would. So
I have one question from Zoom. They wanted to know if you're taking new patients.
I am in fact taking new patients. Yeah. Although I will warn you, this is where I cringe. Again, the number of patients that are out there really outstrips my ability to meet, sadly. And so even though I've been doing 3 to 4 intakes every day, which is a lot. I think that my new patient's schedule is booked out until May. You know, and part of that is that we lost a couple providers. There's, you know, I've realized in my career in medicine thus far, it's 2 steps forward and 1 step back. You know, invariably somebody moves away and those patients need to be absorbed by someone else in the practice. And so we lost the one NP, a lot of her patients that simply can't use telemedicine because they're not tech savvy enough, or they don't have the means, right? And so those folks are being transitioned over to me. And then we also lost an NP down in Woodstock. And so they've been transitioning all of that provider's patients to me.
Wow.
So yeah, there was already a waiting list to come and see us. And then unfortunately we lost some providers. And so it's been challenging to sort of meet the need. Sir.
You have a couple questions, follow up. I thought I heard you say that with personality disorders, there's no scale, it's more stressing.
Yeah, I mean, it's a bit of an oversimplification. Certainly, it would be a controversial thing to say at a professional meeting, right? If there were 1,000 providers in the room. I think
a follow up to that is, so if a person is struggling with a diagnosis, then if a medicine works, that kind of helps move the personality disorder out of the equation. Is that a fair assumption?
absolutely.
Okay.
Right. This is where the world of theory and the real world collide, right? I try to be a pragmatist. And so if someone comes to me and I doubt the diagnosis, I don't like it, it doesn't look tidy, but they've been on lamotrigine for years and it's working, I'm not going to rock the boat, right? I mean, I think that's foolish to rock the boat. Now, unless there's a real distinct reason, right? They're taking something that is, you know, say they're on olanzapine. And I talk to them, I talk to family, I get nothing that smacks of bipolar disorder. I have a low suspicion that this person actually has bipolar disorder. I see no psychosis. The olanzapine is, you know, and again, this is the risk-benefit ratio, right? And you've got to be judicious about this. Different providers might do different things. But you got to ask yourself, what am I getting out of this pill? And is it worth it, right? Is it worth it? You know, because I know that this pill, Freudian slip, I just said poison. If this pill is causing me to have elevated blood sugar, elevated cholesterol, and I know that, and it's unclear what its psychiatric benefit is, then I might actually start doing it. Now, again, I try to be cautious, and so I'm going to do that slowly, right? We're going to probably do this over the course of 2, 3 visits, 3 months or 4 months. We're going to slowly drift off of that pill. I've discovered that, you know, even if the person doesn't need it, when you suddenly discontinue a psychotropic medication, that's a pretty dangerous thing to do, right? I always tell my patients, no sudden moves, right? If you need to come off this medicine, if you want to come off this medicine, I respect that. That's your desire. I'm going to respect that. But let's do it carefully, right? Let's not just cold turkey this at home, you know, on a whim. We got to make sure that we're doing this really carefully and let's do it together. Right?
Yeah, it's interesting you mentioned lamotrigine. That's what this person is taking, and it seems to be working.
Mm-hmm.
And the reason I'm curious is because is there a hereditary factor with either personality disorder or bipolar disorder?
In bipolar disorder, it's very clear. There is a large genetic component. However, it is not, and this is where it gets complicated, it's not one gene, right? None of these are one gene. I wish it was, right? Because then we might be able to do gene therapy or something really, you know, futuristic. You know, it's not one gene that causes schizophrenia. It's not one gene that causes bipolar disorder. It's not one gene that causes depression. Sadly, none of them are that easy. And bipolar disorder, there's been a whole slew of genes that have been implicated in this. There is on a more empiric level, absolutely, there is a genetic component to bipolar disorder, a strong one. We know it. It's I would say a fact at this point. Where the debate comes in is how much, right? You know, the never-ending nature versus nurture aspect of all illnesses, right? How much of this was because of this person's genes? How much of it was because they had a trauma history growing up? How much of this is the substances they've used over the years? How much of this is the other things that affect their health, right? So it becomes very complicated. Suffice it to say, like I was saying, we use medications in personality disorders. We do it all the time. I do it all the time. So I don't mean to contradict myself. It's just, it's not going to be the silver bullet. Now, in the case of bipolar disorder, I have seen medication to be sort of the silver bullet, right? If you get on the right medication, in some cases, I've seen this stabilize people for decades, right? I had a patient that he was on lithium from well before he met me. He had been stable. He was really high functioning. Sadly, by the time he got to me, he was in his 60s and his kidneys were failing, right? Most likely because of that lithium. So then we spent a year and a half, almost 2 years trying to search out that replacement. What can take the place for him? What can keep his mood stable? And it was a bumpy ride. He ended up in the hospital like 3 times before we finally found something that was working. So everybody's wired up a little bit differently. It can take some time. It can be a bumpy ride before you find that medicine that works for somebody. Once you do, and you ride that wave, right? And in the case of someone that has a personality disorder, we use those medications off-label. We target specific symptoms. Lamotrigine is certainly a very common one to prescribe people with personality disorders, and it often works. And again, if it works, go for it, right?
The thought is that this particular person is bipolar.
Mm-hmm.
And by taking the lamotrigine, it's kind of.
And one thing I want to make sure that that's kind of clear. It's in many cases, it's not one or the other, right? It's both, right? And I have had patients that absolutely were bipolar, no doubt in my mind. I saw the mania myself with my own 2 eyes, and they also had all the symptoms that one would expect in borderline personality disorder, right? Classic symptom being the cutting, right? Which is typically present, but not always. It's not exclusive, right? There are people who are not borderline who cut. There are people who cut that are not borderline. It can, however, it certainly ups the likelihood, right? If you've got somebody that's the way that they are managing that stress is to self-injure, I think that the chances that they have a personality disorder have increased substantially.
Thank you.
So, sir, why don't we start over here? We'll kind of move this way, perhaps. I'll keep it orderly.
Quick question, and I'll preface it by saying that our singular experience was positive, but asking your thoughts or experience with genetic testing for psychiatric medication abilities, such as GeneSight is the only company we're familiar with. I know there are others, and I also know there are mixed reviews. For us, it was a very positive experience.
And of course, I'm happy to hear that, right? We always wish people the best.
Right.
The gene testing stuff is also a controversial area.
Yeah.
When I've gone to some professional conferences and listened to people that are far smarter than I am, much more well-informed than I am, I think the distilled version of what they told me for an hour and a half was the testing tends to be pretty good for letting you know if someone has a likelihood to have an adverse effect, right? So for instance, all of our livers are different. If we tested all of our livers, every one of them would be different. The way that they are able to metabolize the different substances would differ. There are different enzymes in the liver, and I could bore you for days with this stuff, but suffice it to say, those tests are pretty good at telling me, like, your liver does not metabolize this list of medications very well. It would probably metabolize these ones better. And so if it's going to metabolize these ones better, you may want to start with this list over here because you're less likely to encounter side effects.
That makes sense.
That's really where it has shown itself statistically to be useful. Sadly, none of them, to my knowledge, have ever shown that any utility for telling me lamotrigine is going to work for you. Prozac is going to work for you. Depakote is going to work for you, right? They only increase the likelihood that Depakote wouldn't be a good choice for you. You're going to not like this. So we get it from time to time. It's awfully expensive. Yes.
I'll add, yes, the testing now is down to $299, which is it's not an insignificant expense.
Yeah.
But for example, with our loved one, on the report that came to our doctor's office. You read with different medications, and in this case, it was Abilify. Abilify, as so many do, come with some black label warnings. Our loved one was experiencing all the black label warnings with Abilify. And the report came back and said, these 2 or 3 medications might work. And in fact, just for us in our case, one of them did become very effective.
It paid off.
Yes.
Okay. Well, I'll tell you what, our practice is always evolving, and you might have inspired me to start getting more genetic testing. So thank you for that. Sir.
Justin, we've had several speakers now over the last 2.5 years, a couple of them from Valley Health. I forget whether it was Tiffany Markwood or Molly Thomason, had given us a list of psychiatrists and counsel in the area, because there's only one of you, and unfortunately the needs are more than just you. Do you have by chance can you send us a current list of area-wide West Virginia, Shenandoah Valley list of psychiatrists, counselors, because a lot of people need that kind of help, and they were very kind to send us a comprehensive list the last time I asked.
I would be happy to ask. I don't personally have one, and I'm pretty new to the area. I just moved here in September, started. So I haven't had too much interaction with the other community providers.
They had a pretty good extensive list. It may have been.
Yeah, I mean, unfortunately, right, as it often happens, it evolves, right? People retire. I've inherited a whole bunch of patients from some other providers. I think it was Dr. McElway had been in the area. It sounded like he had a very large practice, and I've been absorbing some of his former patients. Just some of the names that I hear tossed around. I know that a fair number of my patients that live sort of on the northeast side of the city go to Bloom, which often is telemedicine, and which raises, of course, sort of a separate issue. Can you technologically handle doing telemedicine? Do you have the means, computer, smartphone, etc.? Do you like it? I did telemedicine for a solid year when I was at WVU. I think, I was beaming into these underserved areas in West Virginia that if they weren't seeing me, they might not see anybody. And so it was, I think in that case, sort of a necessary evil for some of my other patients that for whatever reason, they just don't have the transportation would be an impediment to them coming in. I always like it to meet somebody face to face at least one time, right? I just feel like it's a different experience, it's much more personal. And then if the care that I'm providing is pretty straightforward and simple, I feel like telemedicine can suffice. But I think personally it's inferior to a face-to-face visit, right? There's some things that you simply can't do, right? And I hear similar things from my patients, right? I was seeing this person on telemedicine that was a doctor in Florida, and I saw him once and then he disappeared. And sadly that's the way that the model has sort of been working, is that there's not a lot of stability, I think, for a lot of the patients in continuity of care and who they're seeing, right? They sort of see these doctors that have made a contract with a telemedicine, company. They see them once or twice, and they don't really get to know each other. And, obviously my personal opinion would be that it's good to have a relationship with your provider and to know that person and they know you. And, over time, we'll get this right together, right? Because a lot of times we have missteps. We tried a medicine that was a spectacular failure, right? And so, we kind of learn from our mistakes and we forge that alliance over years. I think that really goes a long way. So sadly, I think because of the way that medicine has been, I don't mean to open up a hornet's nest, but medicine has been changed and it's so corporatized, right? That providers get unhappy. They're being forced to see more patients than they want to. They don't like the work environment for whatever reason. They jump ship. They go to another entity. And so doctors are not staying put the same way that they maybe did in the past, right? And that creates a whole host of issues.
Thank you.
You, ma'am.
Yeah, if you're doing a
patient and you're trying to differentiate between bipolar versus borderline personality disorder, can you tell us how you make that judgment? And that has implications for the family.
Absolutely. I think it's an excellent question. And again, it's a very difficult question. I've been doing this for 20 years and I'm sure I get it wrong all the time, right?
No way.
It's a really tough, I think it's a really tough distinction because, again, you can't have both, right? And so I used to try to tell my medical students, my residents, to keep an open mind about this, so that you're not saying it's black or white, it's and or, it's one or the other. It has to be, because it's not accurate. Certainly the experts, when they study this, have shown that's not true. But if we're trying to make a distinction and we're trying to make that treatment distinction, I think that this is borderline personality disorder, which the best evidence for the treatment of that disorder is primarily psychotherapy. And if we want to get even more specific, the treatment of choice, or sort of what is often held up as the gold standard, is something called DBT, which is dialectical behavior therapy, right? And so that's a very different intervention than I'm going to put you on Depakote, right? And then just, that's all we're doing, right? That's the plan. So the outcome could be very different, right? And the Depakote might help this person, even if it was borderline personality disorder. It's just not going to be the magic pill, right? It's not going to fix, it might fix 1 of 6 symptoms or 1 of 7 symptoms, right? And so the biggest thing that I use is this person's mood instability happening over the course of minutes or hours? What are the circumstances around it? And one of the real sort of, I think, kind of red signs or red, kind of neon signs that you may be talking about borderline personality disorder as opposed to bipolar is fear of abandonment, right? And so if the person's mood lability and the acting out behaviors and the rage or the self-loathing is coming from a rejection, that's a different set of circumstances, right? Then I went for a week and I wasn't sleeping and I felt euphoric. And that's also a different thing than, man, I was worrying so much. I hear this all the time, and it's, it sort of eats at my sanity. Other providers will see someone that says, I was up cleaning all night or half the night. Well, you must be manic, right? That's not the same thing, right? Again, it's the context. The context is everything, right? It's not just you stayed up cleaning, it's why were you cleaning? You felt euphoric, you had a motor on you. That's a different thing than I was worrying. My husband decided to leave me, my wife decided to leave me. I'm so upset, I lost my job. I'm gonna stay up all night because I'm super stressed out and I'm gonna clean the damn house. Because that's the only thing I got control of right now. I'm cleaning the house, right? And so again, I think the context is everything here. And it could really change the kind of treatment that this person's going to be getting. So that's really the classic sort of story that I would hear on admissions, right? When I was working in the inpatient realm was my girlfriend left me, my boyfriend left me, my mother or father or sister or whoever said something really nasty to me. It really hurt me to my core. And then I cut my wrist, right? That's different. That's a different sort of thing. That's a rejection sort of thing. And when you look at, say, the diagnostic criteria for borderline personality disorder, one of the core symptoms there is really that fear of rejection, right? These are people that, as a rule, were traumatized, and in many cases, horribly traumatized while they were growing up, and they didn't have clear attachments, right? We all sort of need, in order to grow up and be healthy, we need to have somebody that was around that was sort of, while we were this big and the world was big and scary and nasty and we're not able to feed and clothe ourselves and have shelter, someone needed to be doing that for us, right? And that person needs to not be the person that screams and yells at me or beats me or worse, right? And so that's a totally different sort of pathogenic process for this person. And so not surprisingly, the intervention is going to be different. Sadly, the symptoms a lot of times can look a lot alike. And that's where it becomes really challenging to diagnose people.
It's just my personal experience right now. I do go to Bloom Winchester. And I don't think I had to wait very long, but I have always been able to do in-person appointments.
Nice. Okay, that's good to know.
I do see an NP
Okay.
there. But also in Martinsburg right now, I'm sure you know this, they have a walk-in psychiatric clinic.
Okay.
So you can walk in that day and be seen by a psychiatrist.
Wow.
So,
And is that at WVU?
yeah.
Okay.
So it's
Go Mountaineers.
I
I love it. That's great. And actually, I know Dr. Ang, Michael Ang. I haven't spoken to him in years, but he and I went to residency together, and I know he's one of their folks up there. Really nice guy. No, that's great to hear. I'm glad that there's a walk-in clinic.
Yeah, it's between the cancer center and the main hospital. I think it's Medical Building 1.
Mhm.
So 9 to 4, Monday through Friday. You can just walk in and you have a day.
That's wonderful and hard to not often seen. I'll say that.
Yeah.
Yeah. That's wonderful. I'm glad to hear that.
I have a question.
Yes.
Do you have any experience or views on the use of Spravato for treatment-resistant depression?
That's another great question. Which is, and the reason that I didn't approach ketamine is that it is specifically for treatment refractory depression, right? This is a loaded topic too. Man. So here's the problem. So when I was a professor over at EVMS, Eastern Virginia Medical School, I specifically remember like when the first article came out about ketamine, and my mouth dropped, like my jaw dropped. I said to myself, what in the world are we doing, right? I mean, like this just doesn't even pass the smell test. This sounds so ridiculous. Like, why would we use horse tranquilizer, right? I mean, that's the first words out of a lot of my patients' mouth if they hear Spravato. They're like, isn't ketamine horse tranquilizer? And it's like, well, yes, but that's certainly an oversimplification. The anesthesiologists use it all the time. And actually, it's one of the preferred agents that they use to put people to sleep when they're getting ECT. So I've seen tons of people on ketamine, but that was for an anesthetic purpose, right? And the difference there is ketamine is being given to you by an anesthesiologist in a hospital, right? And it is through an IV. Now, the first data that they got, it was a small study, at Johns Hopkins or Yale or Harvard or one of these places, right? I just remember it was one of the big deals, right? And, and it looked really, really promising. It was like, oh my goodness gracious, like they've got, 20 people and 15 of them are better. You never hear that. Wow. Like that's extraordinary. Like that's really good results. So we need some bigger studies. Let's see if this stuff really works. Is this for real? And, and of course, just from a logistical standpoint, the idea of bringing people in and giving them ketamine infusions, which are time consuming, and you're talking about an anesthesiologist that's now providing your psychiatric care. Are psychiatrists going to do this? That's just not really in our skill set. So from a logistical standpoint, it was really causing some fits. Our friends from Big Pharma, they decided to do something that was novel and maybe brilliant, sort of. They made it so that it was a closely related chemical called S-ketamine, right? Which is a slightly different chemical, and you're squirting it up their nose, right? So now they're not getting an IV, and so they're not sitting there for an hour getting this IV with an anesthesiologist. And from a safety standpoint, my understanding, because I do not do ketamine, full disclosure, and it's not that I'm against ketamine, I just don't do it, right? I have plenty of other things that I'm more comfortable with. But the ketamine, the intranasal ketamine that people are getting, which is brand name Spravato, my understanding is that you go into the office, you get this, this intranasal ketamine, and you sit there for, 45 minutes or an hour or hour and a half, something along that lines. And, you are dissociating and, and this is where it gets really thorny. What happens after they gave you the S-ketamine? What are they doing? What are they doing for you? What are they doing to you? Right? And if you look at the initial studies, what they were actually doing was they were giving people S-ketamine, which the mechanism of action, how this actually works on a chemical basis is pretty complicated. But suffice it to say, one of the things that they thought that was attractive about this particular chemical was that it was going to do something called increase neuroplasticity. This is where I could use my hand-free mic, but bear with me here. Your nerve cells in your brain are like this, right? It's this sort of collection of fingers that are reaching out to each other. And it's the paths that are being traveled that make you, you. These are the, and I'm removing the metaphysical here. I'm talking about pure science. And so we're talking about electrical signals that are being transmitted. And those symptoms with something, remember the phrase, an old dog, new tricks? So the theory here, and I think it has a lot of science behind it, is that you can't teach an old dog new tricks because over time, those nerve cells have become so strongly attached to each other that you can't learn new stuff. Because how you learn new stuff is making a new path. Well, we can, right? I see a furrowed brow there. We can, it's just harder. And there's a lot of science to back that up. If any of us try to learn a foreign language right now, we are going to struggle. It is going to take a lot of energy and a lot of effort, and it can be done, but man, it was hard. Whereas if you take a 4-year-old and you drop them off in Spain, they will speak Spanish, right? I mean, it's going to happen. So, they're with a younger brain, they're more flexible, right? Just like our joints. And so they're able to separate and they can replant those nerve cells. And so the idea was that with ketamine or ECT, there's actually some evidence that ECT can do it. That we're hoping that we can separate those, we can unstick that, and then we're going to allow you to form a new path. Well, that's great. So with ketamine and esketamine, what they were talking about when they first studied this was that I'm going to give you esketamine. I'm going to unstick those nerve cells, and then I'm going to give you therapy. But is that what's happening right now? Generally speaking, no. I would be pleasantly surprised to hear that my colleagues out there are giving people esketamine and then having them go do therapy. That's not what's happening. Not in most places. They're being dosed with esketamine and then they sit there and they stare at the wall or do whatever they're doing, right? And that's really not the same therapeutic intervention. We're talking about a lot more investment of time and effort and man hours, person hours, if we want to be non-sexist. So, we're talking about a lot more energy and a lot more input than just merely, I squirted some ketamine up my nose and now I feel different. Getting a little closer back to your question now, because I digressed, was the numbers are not quite as great for esketamine as they had been, certainly not as glowing as they had been for ketamine, some of those initial kind of smaller studies. Anecdotally, I've had probably about 8 or 9 people that have gotten esketamine, and it was very mixed results, as we often see with any intervention, fortunately. I had one guy who just did wonderful. He was a vet that had chronic pain, just awful back pain, and he was miserable. And he got esketamine, and it just really, really flipped a switch for him. He was doing so much better. It had really helped with his pain a lot. He was more functional. He was a lot less irritable. So I think in his case, win, right? Then I've had about 3 or 4 patients that were kind of like, we got sort of middling results. They felt like it was helpful. Their mood was a bit better. But then the debate started about, is it worth it? This is such a pain in the neck. I've been arguing with the VA about getting this for 6 sessions and now 12 sessions. And I made 1 million phone calls to 1 million different agencies, and it's so frustrating. You can just keep it. I'm done. It was sort of like they just were tired of the whole process of it. And then I had probably 2 or 3 patients that distinctly did not like it. They thought it was a little scary. You're dissociating, which means that you're sort of down in a pit. One of them described it as being in a black pit. They thought it was really sort of intense and a little traumatizing. They didn't like it. So it's not something that I endorse with a whole lot of enthusiasm. I think it's a lot more involved to go through than me switching you from Prozac to Wellbutrin to maybe a different substance, or a different medication. I usually kind of feel, rightly or wrongly, that I need to sort of exhaust other options before I go down the ketamine path. Frankly, By the time that I'm thinking about ketamine for somebody, I'm probably also thinking about ECT because I know ECT works.
Yeah.
For, pound for pound, nothing works like ECT, right? And that's certainly what the data has shown over the years. Now, there's been a few studies that have shown that ketamine got results that were close, right? So they had some remission rates in a few of these studies that were similar to ECT, and of course, people were enthused. We're always looking for a different option because, unfortunately, even ECT, even the one that is supposedly the gold standard, supposedly the best one, it doesn't work for everybody, right? So again, no matter what you do, this is not one illness. Bipolar disorder is not one illness. Depression is not one illness. These are very complex. There's a complex interplay between people's genetic background, between the environmental exposures that they're getting, their current circumstances, their current stresses. So these things become really, really complicated. And so it takes, I think, a lot of effort, a lot of energy, certainly a lot of mental energy to try to figure out what is going to work for this particular person, right? And sadly, I'm the very first to admit it, I make educated guesses all day long, right? I'm trying to guess, based on this particular person's presentation, what is most likely going to work. And sometimes I get it very wrong, We always try to get it right. I love nothing more than getting it right the first time. And I'm like, man, nailed it, right? 10, we got it. And I'm happy as a clam when we get it. But I would say probably it's more common that we're trying 1, 2, 3 medicines or something before we finally get something that is workable, right? Something that has made a distinct benefit and that we decide between the two of us, it's worth it. It's worth the side effects. It's worth the cost. It's worth the hassle of going to the pharmacy, right? Sir.
Yeah, I work at the state mental hospital, but we use we also use clozapine.
Yes.
Do you ever use clozapine?
Absolutely. I was the clozapine guy at the VA, so if you came to the Hampton VA in the last 4 years, I was your man. Yeah, clozapine, it's another one. It's a tough thing, right? Clozapine is the gold standard for treatment refractory schizophrenia, right? So when you look at the studies, you look at the evidence base over the years, no antipsychotic, and again, we're talking about a group of people, not an individual, an important distinction, right? If you take 1,000 people and you give them clozapine, 1,000 people with schizophrenia, and you give them clozapine, the largest number of them will improve on clozapine as opposed to the other ones. That does not mean that it is necessarily a better medicine for a particular individual, right? So that's an important distinction. Clozapine, if clozapine works so well, then why don't we use it? And this is the never-ending debate. People get real passionate about this. Some of them get really angry. It was not uncommon when I was, when we were still getting the paper journals, which those have sadly kind of gone away. Teardrop makes me feel old. But when we were getting our paper journals and we were looking through the journals, there were often these articles written by someone impressive that was telling all the rest of us we're terrible doctors because we don't have enough people on clozapine. We're failing. We are cruel and leaving these people untreated. I think that's really a gross misrepresentation and an oversimplification of, again, a rather complex issue. Clozapine is a really hardcore medicine, right? And we know that it has this side effect that is called agranulocytosis. So basically, fancy word for it destroys your blood cells, your white blood cells specifically. And even more specifically, it is the something known as PMNs or macrophages. These are the ones that are really responsible for fighting off bacterial infections. And so you have to be super careful with clozapine. It's not a common side effect, but it is a life-threatening side effect. And I actually had a man that had this. And once you have a case like this, when you get burned, it makes you very reticent to go that way again, right? This guy almost died, and and we were friends, right? We're not supposed to be friends with our patients, but we do. Like, we become friendly, and certainly we care about each other. And so it tears at your heart, right, to see somebody like almost die from something that you're giving them, right? It's hard not to feel responsible for that. I used to always tell my med students, my residents, when it comes to clozapine, the sad part about clozapine is that all the people that need clozapine aren't good candidates for clozapine, right? Because you have to go and get your blood tested every week. Can you imagine getting stabbed once a week? I hate giving blood. I do it begrudgingly, you know? And so the idea that you're going to take some person that's really severely mentally ill and have them go and get a blood test once a week, that's a tall order, right? You've got to have really good case management from, like, say, a local CSB or state hospital, or, you know, family members that are just really looking out for somebody. That's a tall order, right? I mean, that's a lot. And it's so much, the feds have recently relaxed the rules, which of course is also controversial, about before the pharmacy simply would not even release the clozapine prescription. It was a weekly prescription. I could not give you more. It was under a really, like, sort of rigid program through the federal government. It was called REMS. They have done away with REMS, again, for better or for worse. And time will tell whether that was a smart thing to do or not. But it's a big deal because, you know, now the fear is that since the feds have relaxed the rules, that's good because that's good because we're going to be giving clozapine to more people with schizophrenia or bipolar disorder. They do use it for bipolar disorder in rare cases, pretty rare cases. And so they give you this medication that, yeah, okay, so this seems like it works better. This is good. I'm functioning better. But, you know, I really didn't feel like getting my blood test. I didn't get it. Is the pharmacy still going to fill it? Maybe they might do it, you know, and then maybe you're getting, you know, that drop in your blood cells and you get an infection, and it's a really serious infection. And, you know, your pharmacist isn't really paying attention to this, and your doctor isn't really paying attention to this. Who got the results? When did they come in? Who's responsible for it? So it has gotten a little messy. As of right now, I do not have any patients on clozapine at Valley Health. When I was at the VA, and they actually, for all of the criticisms that the VA gets, they get some things right. And they had a really good system for REMS. I mean, the pharmacists there were like top notch. And, you know, and they really made my life easy. They would hand me the results. They would make sure that I had seen them. We would co-sign it together. It was really a nice system that they had. And within that system, I felt comfortable prescribing it. And I was prescribing Clozaril for probably about 10 patients. So maybe 10 or 15 of my patients of 850, right? So not a real common thing that I was doing. But again, in some cases, it made sense. Now, and one might argue, like, if I was at a conference with 100 psychiatrists, would they be critical of me because I was undertreating, right? They might say, your numbers are way off. Like, you have 850, like, you know, bipolar and psychotic patients, and you're only using it in 15 people. What's wrong with you, right? That would be a possibility. Ma'am.
You mentioned specifically when the diagnosis is for the younger the person, the diagnosis, the prognosis is worse. What do you mean by that? What is the prognosis?
Yeah, and it gets a little complicated because different people define it in different ways. Certainly some common things, like if you were looking at studies, outcome, you know, some pretty kind of typical outcome measures would be number of hospitalizations per year, number of hospitalizations lifetime, length of hospitalizations, suicide attempts, suicide completions, you know, a little bit more rare, sadly, I think, in my humble opinion, quality of life measures. And of course, quality of life is an elusive thing, right? What is happiness? You know, I would say IKEA, right? You're living in Norway, or, you know, you're living in Sweden. That's the perfect society. You know, it's hard to say, like, what is, and the reason I bring that joke up is that despite the fact that, you know, it's sort of an oddity, despite the fact that, like, Minnesota is cold, and I know there's some chaos up there right now. We won't go there. But, you know, like, statistically, Minnesota and often, like, ranks as the happiest place in the United States. You know, and it's like, but it's miserable there. Like, my wife's from Minnesota. You couldn't pay me enough to live in Minnesota. It's bitter cold. It's dark, right? And so what is it? Is it a genetic thing? Because they actually have a large, like, Norwegian and Scandinavian population. So is this some sort of genetic thing? You know, like, why are these people happy? You know, the twins can't win and they're still happy. So it's kind of, it's interesting. Where was I going with this? What was it? Oh, prognosis, yes. So it's like, it's sort of hard, and quality of life measures are sort of elusive. But there's a couple things that they've come out with, and again, they all have sort of their flaws about, does this really map humanity? Like, I mean, what's happiness? Right? So it becomes a little more philosophical. But there are a few measures that they attempt, right? And they're reasonable. I mean, you read them and you're like, yeah, I mean, that sort of sounds like a happy person, I guess, maybe. But those are some of the things that they look at. Just and perhaps like a little easier explanation would be, those are the folks that are in the hospital more, right? And that's sort of an indicator of how well is this person doing? Do they need to be in the hospital? But again, then that becomes complicated by accessibility to care, right? So, does the fact that people are being hospitalized more, is that success? Or is that a failure? Just like when you do crime rates, right? We're arresting more people. Is that good? Does that mean that there's less crime on the streets, or does that mean there more crime on the streets, right? So it's actually, it becomes rather complicated to sort of define whether we're being successful or not.
I want to take one more question and then we'll wrap into some post-presentation fellowship time.
Sure, ma'am.
Like the hereditary genetic component and life experience stuff contribute to bipolar, but is there also situations where it's an imbalance in like brain chemicals or anything like that?
Man, you guys are brilliant. I'm telling you, you guys have asked the best questions. These are such wonderful questions. It is, boy, if you ever figure out what causes bipolar disorder, please let me know. We will have a Nobel Prize.
No.
It is actually really complicated. I think a very drastic oversimplification of this would be to say, and the easiest explanation, which is why we often fall back on it, is this idea of a chemical imbalance. There are some smart people out there, much smarter than me, that would absolutely like bristle at what I'm getting ready to say. Yes, there is a chemical imbalance, but what is that chemical imbalance? I think the easiest explanation is that there is an imbalance of a couple neurotransmitters in our brain. The ones that have been most frequently implicated are dopamine, serotonin, and norepinephrine. But what I used to always try to tell my learners was, this is way complicated. This is not just how much serotonin do you have in your brain, how much norepinephrine in your brain. It's all about when and where and how much. Mm-hmm. So again, you're talking about multiple variables here. And what they have actually shown most frequently is, when it comes to the mood part of bipolar disorder, it appears to be, as with PTSD and depression. So again, perhaps not surprising that these things run together. Those are all the same part of the brain. It's called the limbic system. Sometimes more specifically, they'll refer to the amygdala. That seems to be really kind of prime time territory for dysfunction. And it is a part of the brain that is developing when we were children, as they all are. But they think that, the experts think that that's where a lot of this pathology comes from, is this really deep part of our brain that has to do with threat assessment. Is the world a safe place for me? I'm this big. And that sticks with us forever, right? And so it's tough. The part of the brain that seems to be dysfunctioning when it comes to the mood and the sad part, the sadness and the euphoria that sort of, swap places with each other, has to do with the limbic system, we think. The parts that have to do with the gross misjudgment and poor judgment is the frontal part of the brain, specifically the prefrontal cortex. This is the part that is my filter that tells me, you know what? It'd be super fun to drive my Harley 100 miles on the highway, but maybe I shouldn't, right? The other one that, more amusing would be some of the, I used to tease my med students, manic people say the darndest things. I mean, there's no filter. And if you ever want an honest assessment of how you're doing in life, ask a manic person. They will give you the unvarnished truth, right? And sometimes comically so. But it's that filter. They've got no filter. They'll say wild and crazy things that are just like, wow, I can't believe you just told me that. You're right, but that was cruel. I have gained weight. They would often tell that they'll comment on your weight, they'll comment on your physical appearance, and you have to have a thick skin for that sort of stuff. And the judgment, not least of which is the sexual indiscretions that often will accompany manic episodes. And again, I have seen countless marriages wrecked because someone got manic, that filter is shut off. And, it seemed like a good idea at the time. And there will be a lapse of fidelity. I actually had a patient, I knew him and his wife. They were sort of prominent local people, owned a business, and he had a manic episode. He withdrew $60,000 from their bank account. He hopped on a jet plane. He flew all over the country having sex with various women, and donated a whole bunch of money to charity. Finally apprehended by the police. He was societally conscious. He went to Sherwin-Williams, bought out all the pink paint that they had, went to a building that he did not own, because he did own a number of buildings, but he went to a building that he did not own, and he painted pink all over the side of the building to raise breast cancer awareness before the police finally apprehended him and brought him to me. Yeah. And that marriage did not survive, right? And it's sad because I'm sure that he didn't want to do that. And you also, on the other hand, I mean, certainly I understand why his wife was upset, right? There has been a fundamental breach here of our agreement, right? And so these manic episodes, I mean, they have profound effects on people's life, right? Which is why, I mean, I always took it very seriously. It's like, I owe it to this person, I owe it to society to make sure that this person is as stable as they can be before they leave these doors. And that would often make me their enemy. They hated me, and they could be vicious, right? But again, that's my role. That is why I'm here. And you have to have a thick skin, and you have to just do it, right? I'm sure that you've gotten your fair share of resentment over the years. Yeah, I mean, and sometimes it makes you feel bad, right? I mean, because we're people too. But and you understand their frustration, right? You've taken their rights away from them. They're not able to move freely the way that they would like to do. And they can become very resentful about that, not surprisingly. But sometimes it just has to be done. Sir, are we all done? Are we cutting me off?
Well, why don't we transition to sort of a post-presentation fellowship, Lynn?
I have a quick question. Is it okay if I ask it real quick?
Sure.
I've been reading on Facebook about limbic system rewiring. Do you have any comments on that?
I don't. I would love to rewire people's limbic systems. I'm not sure what they're proposing, and so I'm afraid I wouldn't really have any intelligent comments about whether it's legit or not.
I have a friend that had a lot of medication allergies, a lot of health issues. I know she had Lyme disease, and her husband posted that she's now able to eat most foods, and it's really turned her around. I'm trying to get in touch with her to find out more.
Sure.
Okay, thanks.
I will keep it on my radar, though. It certainly sounds interesting. It's one of those things that sounds wonderful, but the question is, what are we talking about here, right? And is there good science behind it? Again, not to be cynical, but what's our source? Who stands to gain from this? And of course, I'm going to give greater weight to a study that's been done by a governmental agency or a university that presumably has less of a conflict of interest than someone who is a purveyor or of a particular drug, right? The drug company studies are always and should always be viewed with a certain amount of skepticism, right? Because this is someone who stands to gain financially from this product. And guys, I'm afraid I have to run. My wife is actually coming back. I've talked a lot longer than I was supposed to. And so I'm gonna have to run, but it was such a joy talking to you guys. Such a nice group of people. Hopefully I gave you some useful information. And it was really a good time.
Thanks, you,
Thank you.
Still live. No worries, no worries. Dr. Petri, thank you so much.
You are welcome.
For the information that you gave us here today.
No, I didn't bring it. I'm thinking I'm a terrible businessman, but I am on the internet. And yes, if anybody was looking to work with me, I am accepting new patients. Like I said, it's going to be a while, sadly. I think some of my new patient appointments are way out in March, or excuse me, April or May. But yes, it was a pleasure. So thank you.
Wow. Phew. Yeah, I hope you all found that very helpful and informative. Thanks again, Dr. Petri, for spending the time with us this morning and giving us all this just wonderful, wonderful information about bipolar. We'll have to have you back. Yeah. And take care.
Thank you.
All right. Thanks to everyone that joined us on Zoom today. And we'd like to let everybody know that we've got another informational seminar in February. Fred Sabia will be talking about bipolar disorder from a counselor's perspective. So a continued informational seminar in this series on Saturday, February 21st. Same time, we opened at 9:30 for registration and fellowship. Speaker starts at 10 and goes till whenever we're complete. It could be close to 12, sometimes it's 11:30.
Yeah.
And then our support groups, the first and third Thursdays from 5:30 to 7 p.m. each month. The next one is on February 9th. And then I put up our website to share with y'all. Hopefully you can see that. It's YourNotAloneMinistry.org. It has, I'll grab the mouse and see if it'll work from over here on the podium. Oh yeah. But there's an About Us section. The events are also down here, and there's always a quick list of dates. And this resources tab is really extensive under each section for either immediate care, biblical counseling, web links, media, addiction resources, and a lot more help and info. Fellowship Bible Church, that allows us to have our seminars and our support groups here, has a very strong biblical counseling program that is just outstanding. In the back of the room is our resources table. There are books, pamphlets, and all kinds of things like that you might find helpful. And raise your hand if you're volunteering for You're Not Alone Ministry. We're going to hang out if you want to have any discussions afterward to get more information about the ministry. And then I'm going to wrap us in prayer. The information presented today was just outstanding. A lot of science, a lot of medicine. And I'm a fan of backing out to a big picture view. I call climbing up to the 30,000 foot view. And the 30,000 foot view is that we live in a fallen world. And our hope is in Jesus. And what Jesus said was, take heart. He said, in this world you'll have trouble, but take heart, I have overcome the world. And he's where our hope lies. So the prayer is, if you'll bow your heads with me, we think about what Paul wrote to the Corinthians. Father God, when we read, therefore, we do not lose heart, but though our outer person is decaying, yet our inner person is being renewed day by day. For a momentary light affliction is producing for us an eternal weight of glory far beyond all comparison. While we look not at the things which are seen, but the things which are not seen. For the things which are seen are temporal, but the things which are not seen are eternal. Lord, we're glad that, and we're joyful that you are in control of everything fallen and glorious, and we have our hope in Jesus. And it's in his name we pray, and we thank you for Dr. Petri's presentation today and the people that have come here. We hope that we meet their needs, and through you meet their needs. We pray all this in Jesus' name. Amen. All right, I'm gonna stop the Zoom, and then we can answer any questions that y'all have.
You got it.
I said, cool, hang on.
Again, this next one is also not anymore, but. Why so?
Hang on a little bit.